Chronic knee pain is a persistent or recurring discomfort in the knee that lasts for more than 3 months. The most common cause is osteoarthritis, a degenerative joint disease that affects millions worldwide. This pain can gradually worsen, impacting daily activities and overall quality of life. In this video, we'll explore the latest evidence-based approaches to diagnosing and managing chronic knee pain, with a special focus on osteoarthritis. We'll also discuss how a multidisciplinary approach can help patients regain mobility and comfort. Let's begin by understanding the scope and impact of chronic knee pain. Osteoarthritis of the knee is a leading cause of disability, especially among older adults. Globally, about 16% of people aged 15 and older, and nearly 23% of those over 40 are affected. The burden is not just physical. Chronic knee pain leads to significant psychological distress and socioeconomic costs, with estimates reaching over $140,000 per person in the United States. As populations age and obesity rates rise, the incidence of knee osteoarthritis is expected to increase. Understanding these numbers highlights the importance of effective management strategies. Several risk factors contribute to the development of knee osteoarthritis. Advanced age, particularly over 55, is a major factor. Obesity increases the load on knee joints, accelerating cartilage wear. Women are more likely to develop knee OA than men. Previous knee injuries and certain occupational activities that stress the knees also raise the risk. Trauma accounts for 10–15% of cases. Recognizing these risk factors is crucial for early intervention and prevention strategies. Patients with knee osteoarthritis typically experience insidious, gradually worsening pain. The pain is often mechanical, worsening with activity and improving with rest. Early on, pain may be intermittent and sharp, but as the disease progresses, it can become constant and accompanied by joint stiffness, swelling, and reduced function. Severe cases may lead to significant disability. Some patients report flare-ups with increased warmth and swelling, while others may experience burning or electrical sensations, indicating nociplastic or neuropathic pain components. Thorough musculoskeletal and neurological examination is key to diagnosing knee osteoarthritis. The clinician inspects the knee for redness, swelling, muscle atrophy, and changes in skin texture. Palpation helps detect bony enlargements, crepitus, and tenderness along the joint line. Assessing gait alignment and range of motion provides further clues. Special tests like the Lachman and Dror tests evaluate ligament stability. Comparing the affected knee with the opposite side can reveal subtle differences. These steps help differentiate OA from other causes of knee pain. Diagnosis of knee osteoarthritis often relies on clinical criteria, such as age, morning stiffness, crepitus, and bony changes. The American College of Rheumatology provides guidelines that combine history, physical exam, and sometimes imaging. While X-rays are the gold standard for confirming OA and grading its severity, MRI can detect early cartilage changes. However, radiographic findings don't always match symptom severity. Additional tests may be needed to rule out other conditions, especially in younger patients or those with unusual symptoms. Not all knee pain is caused by osteoarthritis. Other conditions to consider include rheumatoid arthritis, crystal arthropathies like gout, infections, post-traumatic injuries, and persistent post-surgical pain. Referred pain from the hip or spine, as well as mechanical issues like malalignment or ligament injuries, can also mimic OA. A careful history, physical exam, and targeted investigations help distinguish between these possibilities, ensuring the right treatment path is chosen. First line of treatment for knee osteoarthritis is conservative and multimodal. Education about the disease, physiotherapy, weight management, and lifestyle changes are essential. Structured exercise programs, both land-based and aquatic, help reduce pain and improve function. Gait aids, braces, and self-management programs can further support patients. These non-pharmacological measures are safe and effective, but their implementation in clinical practice can be challenging. Nationwide initiatives have shown that consistent exercise and education improve outcomes. Lifestyle changes aren't enough. Medications are introduced. Nonsteroidal anti-inflammatory drugs NSAIDs and paracetamol are first-line options, with NSAIDs generally providing better pain relief. Duloxetine, an antidepressant, is recommended as a second-line agent. Topical capsaicin may offer modest benefits. Opioids are reserved for select cases due to their risks. Glucosamine, chondroitin, and biologicals are not recommended. It's important to tailor medication choices to each patient's comorbidities and risk factors. Conservative measures fail. Intra-articular corticosteroid injections can provide short-term pain relief. These injections reduce inflammation within the joint, especially during flare-ups. The effect peaks around 2–4 weeks and typically lasts a few months. While repeated injections may decrease cartilage volume over time, serious adverse events are rare. The decision to use corticosteroids should be individualized, considering both benefits and potential risks. Hyaluronic acid injections, also known as viscosupplementation, aim to restore lubrication and cushioning in the knee joint. The evidence for their effectiveness is mixed, with some studies showing modest benefits and others finding little difference from placebo. Adverse events are generally mild, such as temporary pain or swelling. These injections are conditionally recommended, mainly when other options have failed and after shared decision-making with the patient. Platelet-rich plasma (PRP) therapy involves injecting a concentrated solution of the patient's own platelets into the knee. PRP contains growth factors that may promote healing and tissue regeneration. While some studies suggest PRP can reduce pain and improve function, the evidence is inconsistent and the quality of data is low. PRP is not routinely recommended outside of research settings, but may be considered in select cases. Radiofrequency ablation (RFA) targets the sensory nerve supplying the knee, interrupting pain signals. There are several RFA techniques, including conventional, cooled, and pulsed methods. Studies show that RFA can provide significant pain relief for 6 months or longer in many patients with moderate to severe knee OA. The procedure is generally safe with minor side effects like temporary numbness or bruising. RFA is recommended for therapy-resistant cases where other treatments have failed. Genicular nerves are branches of the femoral, obturator, and sciatic nerves that transmit pain from the knee joint. RFA typically targets 3 main nerves, but some studies suggest that treating additional nerves may improve outcomes. The procedure can be guided by ultrasound or fluoroscopy for precise placement. Ongoing research aims to optimize which nerves to target and refine the technique for maximum benefit. Chemical ablation uses agents like alcohol or phenol to destroy the genicular nerves and reduce pain. While some case reports and small studies show promising results, the evidence base is still limited. Chemical neurolysis may be considered in research settings or when other interventions are not feasible. More studies are needed to establish its safety and effectiveness for chronic knee pain. Surgery is reserved for patients with severe osteoarthritis who do not respond to conservative or minimally invasive treatments. Procedures include arthroscopic debridement, osteochondral repair, osteotomy, and total or partial knee replacement. Total knee arthroplasty is the definitive treatment for end-stage OA, providing significant pain relief and improved function for most patients. However, up to 20% may remain dissatisfied or experience persistent pain after surgery. Wrist stimulation, including peripheral nerve stimulation (PNS) and spinal cord stimulation (SCS), is an emerging option for refractory knee pain. PNS targets nerves near the knee while SCS delivers electrical impulses to the spinal cord. Evidence for these techniques is still limited, with most data coming from small studies or case series. They may be considered in select patients with neuropathic pain or after failed surgery, but are not yet standard practice. All interventional treatments carry some risk of side effects. Corticosteroid injections may cause temporary pain, swelling, or rarely infection. Repeated injections can reduce cartilage volume. Hyaluronic acid and PRP injections are generally safe, with mild short-lived side effects. Radiofrequency ablation may cause transient numbness, bruising, or rarely burns if not performed correctly. Careful patient selection and technique minimize these risks. Image-guided techniques, such as ultrasound or fluoroscopy, improve the accuracy of intra-articular injections and nerve ablation procedures. Ultrasound allows real-time visualization of soft tissues and needle placement without radiation. Fluoroscopy provides detailed images of bone structures and is especially useful for targeting nerves. Studies show that guided injections have higher success rates and may reduce the need for surgery. Managing chronic knee pain requires a team approach. Collaboration between primary care, pain specialists, physiotherapists, and surgeons ensures that each patient receives individualized care. Psychological support and integrative therapies can address the emotional impact of chronic pain. Regular reassessment and adjustment of the treatment plan help optimize outcomes and improve quality of life for those living with knee osteoarthritis. Summary: chronic knee pain, most often due to osteoarthritis, requires a comprehensive stepwise approach. Start with education, exercise, and weight management. Add medications as needed, and consider minimally invasive interventions like corticosteroid injections or radiofrequency ablation for persistent pain. Surgery is reserved for severe refractory cases. Ongoing research continues to refine these strategies, offering hope for better outcomes. Remember, a multidisciplinary, patient-centered approach is key to managing chronic knee pain effectively.